Hi, guys. Jack Wickstead from Beth Israel. I want to thank Tasia for helping to set this up and for Kieran for inviting me to speak with you today. They've asked me to speak about primary total hip replacement for acetabular fractures. Um, and, it's a good topic, but I want to start with a big caution. This is a technically complicated topic. And unless you have, a wide range of implants and technical support in your operating room, I would undertake this with a great deal of caution. These are some of the bigger cases that we do, and I usually have myself, as a trauma surgeon, as well as one of my arthroplasty colleagues, who do nothing but complicated arthroplasty doing these cases, and we struggle with these. So, I'm warning you ahead of time. Take this topic with a grain of salt and be careful before you jump into the swimming pool. By way of disclosures, I don't have any disclosures really for this talk. In general, acetabular fractures these are technically challenging. These certainly aren't for the faint of heart. They require, fairly large approaches. Simple acetabular fractures, posterior wall fractures, posterior wall, posterior column fractures, not badly displaced transverse fractures. Those are all fairly technically straightforward to fix. And I think those also make the best candidates for primary total hip arthroplasty. One of the problems that we run into with acetabular fixation is that when you get complications from these surgeries, they tend not to be small complications, and they tend to be difficult to treat. So sciatic nerve palsy, very difficult to treat. Failed fixation in an acetabular fracture, problematic. Infected acetabular fixation leads to infected joints, leads to girdle stone. So acetabular fractures in general are complicated. We could say the same about hip replacements, and these complications aren't really additive. They're really multiplicative. So when we're talking about doing total hip replacements in the face of an acetabular fracture, we really have, quite a long list of complications that we need to take advantage of. There's not a lot of data on this subject because these injuries are fairly unusual. The data is largely a series of case series and expert opinion. So my talk here really is little more than that, right? It's just case series and expert opinions. And I'm going to show a couple of my own cases that, for which we've done acetabular fractures for good reasons. With indications, the indications for these are fairly straightforward. Mostly these are older patients, and I'm talking, 65 and above, cases with high failure rates that if you were simply going to treat them with ORAF, they would fail. There's some argument about whether or not pre-existing arthritis is a good reason to do acetabular fractures. Again, fortunately, fairly unusual for us to get acetabular fractures in patients with pretty significant pre-existing arthritis. In those situations, most of those really, would fall under high failure rates if you fix these things primarily. And honestly, my primary indication for this is in patients in whom I know that my fixation is not going to work long-term. And so, we're going to assume some more risk at the short term to try and save them from a second operation. That second operation, total hip replacement after primary acetabular fixation, has fairly high infection rates, probably in the 15 to 20% range. So, that gives you pause. This is a sort of typical case for me that I think is a good candidate for primary total hip replacement. This is a 65-year-old patient who presents with a, fairly straightforward posterior wall fracture dislocation. The patient was initially closed reduced at an outside hospital, and they were going to plan to treat the patient non-operatively. They really didn't have any post-reduction x-rays, so we don't really know how good their reduction was, but by report of the surgeon, it redislocated several days later. They took him back to the operating room, relocated the patient, then it dislocated again, and then they for recurrent instability, transferred her in to see us. So this is a patient whose femoral head has been sliding in and out of the acetabulum, for days on end. In that case, there's some good arguments to be made in favor of replacing them. Why replace them? Well, for patients who've had multiple dislocations, the head is likely damaged. The acetabulum on the cartilage on the acetabular side is certainly going to be damaged. And from the standpoint of what's it going to take to fix the acetabulum to make it possible for you to have a hip replacement, that's fairly straightforward. This is a large posterior wall fragment. We're going to get good fixation on the posterior wall. The cartilage may be bad, and so the patient's at very high risk for getting a hip replacement down the road, but we're going to get good stable fixation with a very straightforward acetabular repair. That's going to allow me to put a straightforward hip replacement in the patient. The arguments in favor of primary fixation really are that you have better options if things go badly for you. If your ORIF and your total hip goes badly, gets infected, you have loose components, you have very little option short of a girdle stone, getting rid of the hip altogether, and that's going to be a bad news for the patient. I would say also that be careful of fixing complex acetabular fractures and then trying to put a total hip in them, because if the acetabular fixation is complex and it doesn't hold well, then the cup isn't going to hold well. So I tend to be biased towards simple acetabular fractures in older patients getting primary total hips. In this case, we took an isolated posterior wall fracture. And you can see, here on the left-hand side, fairly large wall fracture. There's the piece on the right-hand side that's displaced superiorly. And, there's that large posterior wall acetabular fracture. So we know we're going to get good fixation on that wall. So we can do a standard posterior approach to the hip. You don't have to do a fancy Coker-Langenbeck. You can just do a standard, straightforward posterior approach because you're not trying to protect the blood supply to the femoral head. You release the piriformis, release the short external rotators, and, expose out that posterior column. And then you can put a plate right on that posterior wall, right down to the posterior column. You're staring right at it for your total hip approach. And then you can go, ahead and give them a fairly straightforward total hip replacement. You can see in this case, we used a standard size cup. We did use some extra screw fixation in the cup. So that's a multi-hole cup. If you're limited in your acetabular components, don't go down this road. These are components where I need to have multiple sized cups. I need to have multiple options in terms of the cups going up to large sizes, and I need multi-hole cups. You can see we put 4 screws into this cup, which is way more than we would use for a standard cup. But again, that's just a reflection of the fact that these acetabular fractures are quite unstable. The bone quality is quite poor, and we really need a multi-hole cup to get this to work. This is a nice paper, a little case series of 16 of these with, reasonable follow-up. So reasonable size series, reasonable follow-up. And I think their experience mimics my own. So we'll just go through a couple of, findings here. They've got 16 cases. In all cases, they use the posterior approach. My strong advice to you on this is not to get fancy. Do a posterior approach. We've had some situations where patients have had bad protrusio deformities and needed a stop approach with a plate along the anterior column, and then we were able to flip them and give them a total hip. Again, that's pretty complicated surgery. So make sure that you have, good imaging if you're going to do that, good support. Those patients can get major bleeding complications from anterior approaches. So, you need to make sure that you've got, good blood bank support and good anesthesia support. In this case series, the vast majority of these patients were women, 62%. Mean age of 80, right? So these are older patients with really poor bone quality, and not a lot of, margin for error here. In this case, the vast majority of these were straightforward, A3 type, comminuted posterior wall fractures. 16 of these patients, 6 out of these patients, 6 out of 16 of these patients needed a jumbo cup. So this is a nice case here. They fixed the posterior wall with some screws. They didn't put a plate on it, but they were able to get a jumbo cup in there. You need to have jumbo cups if you're going to be doing these cases. If you're limited in the acetabular components that you have available to you, these are probably not cases that you're going to want to do. You need multi-hole cups as well. So again, you can see in this case, they've used quite a number of screws to augment the fixation of that cup to get you through that initial period where the cup's going to ingrow and then become stable. Even when you do this, you're going to have some problems. Heterotopic ossification here is quite common. This is a big approach. You're doing a posterior approach. You're fixing the acetabulum. You're releasing all those short external rotators. Your abductors are going to get beat up. And then you're going to do a hip replacement on top of it. So you're doing quite a lot of pelvic work here. And those patients are going to be a setup for getting heterotopic ossification. So that's definitely something I talk to my patients about ahead of time. Other complications related to this, long-term stability of the acetabular component. When patients come back to you and they're complaining of groin pain a year out or 2 years out, you have to be very suspicious of the cup. This is an 87-year-old patient. You can see that the cup has medialized very badly, probably underfixed in the beginning, probably not great fixation in the cup itself. But again, difficult problem to deal with now because a patient may well have a discontinuity, through that transverse portion of the fracture. This now becomes both a reconstructive problem for the component, but also a reconstructive problem for the pelvis. Oftentimes, these patients need a repeat formal posterior approach. You have to plate the posterior column. It's going to require some bone grafting, and it's going to require a revision cup, with, again, multi-hole cups or even, jumbo cup or some fancy augments on that cup. So these are, technically complicated and require, good implant selection if you're going to make this process work carefully for yourself. All right, we're going to just go on pause here for a second, Tasia. Okay, so sorry for that brief pause. This is the last case I want to show you. This is a 79-year-old woman, again, treated at an outside hospital, who had an attempt at closed reduction in the emergency room. And then, you could see in the left-hand side here was dislocated and then had repeat films here on the right-hand side. And you can tell that there's something not quite right about this femoral head here. Sorry, Tasia, can you just put on pause real quick? Again, sorry for the technical issue. Here we have the relocated head, and you can see there's clearly something inferiorly going on that's just not right. When you look at the CT cuts, it's fairly obvious to see what's going on. The patient has a fragment up here in the top left-hand corner that's probably blocking the reduction to a certain degree, and large posterior wall fracture, a lot of marginal impaction that you'll see here. And as you go down into the lower cuts, you'll see that the head is actually kind of perched on that posterior wall. And then when you get to the very bottom of the acetabulum, you can see that there's really even some fracturing of the head here. So this is a case that's giving me real pause about whether I can fix this. Not because I can't technically fix it, but because if there's a lot of damage to the head, then it's not going to work. Even if I fix it, I'm going to get a poor result. I spoke with the surgeon who transferred her in, and they had done several attempts at trying to get this to stay reduced in the emergency room. It sounds like they were fairly aggressive with this old lady. And when we got her to surgery and took the femoral head out, you can see down here in the bottom, this is with that inferior portion of the head. This is where that they had attempted multiple attempts at reduction and had really stove in the top part of the head. So this is the cut that we made to remove the head, right? And you can see here inferiorly, this is where it was broken on that CT scan. But the whole entire, this is the dome of her acetabulum. This is where she's walking. Like clearly, even if you fix this, it's not going to work. She's going to very rapidly disintegrate and need a total hip replacement anyway. So in that case, we went ahead and went straight forward for the total hip replacement. When we got the posterior wall fragment out, it just turned into crumbles. So there really was not even a decent posterior wall for us to repair. Now, in those situations, if you really need a posterior wall and you don't have one, you certainly can resect the head and use the head as an autograft and, bolt the head into the defect and use this to help reconstruct your defect. In our case, probably a good 80% of the cup was still well covered. So we went ahead and just used the acetabulum that we had, and we just reamed her a little bit deeper. So you can see we've got a little protrusio going here with the cup because we've reamed her a little bit deeper. We used multi-hole fixation, but we had a nice stable construct here. Standard, good cortices down distal, so we were able to use a standard press fit stem as well. Just a word on the stem side, when you're dealing with these, 75, 80-year-old patients, many of them will have, a Dorsey type canal, and a press fit stem is a poor choice for them. And they're going to need a hybrid, fixation of a press fit cup with a cemented stem. So just by way of conclusions here, there's a few things you really must have if you're going to take these things on. You've got to have multi-hole cups. And you've got to have jumbo cups. If your cups don't come up to, 65, 66 size, you have a problem. I wouldn't suggest doing this. You need to have good fluoroscopic guidance just to make sure that you're getting a good fixation of your acetabulum. The best patients where this really works are for simple acetabular fractures. If you have a posterior wall, if you're doing a posterior approach anyway to fix the acetabulum and you're right there, that's a good case to do a total hip on. If you have to do an anterior approach and then flip the patient into a posterior approach, you might want to think about just doing the anterior approach, letting the patient settle down, and then bring them back at a later date for the, for the total hip replacement. Largely because these things do have high complication rates. And if you've gone ahead and put a total hip in them and things go south, you really don't have a lot of options. Best indications really for these patients are, look, I'm going to fix them, but I know my fixation is doomed, as in this last case where, I knew this was doomed. The femoral head was never going to survive. So in that case, I think the additional risks of putting a total hip in are certainly justified. Okay, thanks for your attention. Appreciate it, Tasia. Thanks for bearing with me.